Good evening, doctors. Warm regards from Bayer Oncology. Thank you for joining tonight's discussion on prostate cancer. Today we have Dr. Stalin Bala, sir. Sir is a head of the department, senior medical oncologist from Mahatma Gandhi Cancer Hospital, Vishakhapatnam. Sir will be set the contest of prostate cancer and then he will introduce the other speakers. Sir, over to you, sir.
Yeah, thank you, Sandeep. Thank you for that introduction and thank you, Bayer, for this opportunity. So the today we'll have two talks and few case presentations and a small panel discussion regarding the recent developments in the management of metastatic hormone-sensitive prostate cancer. Also, we'll gain some insights on the evolving scientific narrative for the use of darolutamide doublet and triplet combinations, because we know that with the development of recent classification of metastatic hormone-sensitive prostate cancer into high volume and low volume disease, and high volume disease patients behaving very aggressively and needing the more and more intense treatments. And we have now good data of using triplet combinations with the darolutamide in high volume, high risk disease, and also there is a data of using darolutamide based doublet combination. So in a nutshell, in the next 1 to 1.5 hours, we'll learn on how the treatment landscape of metastatic hormone-sensitive prostate cancer has changed and what are the recent developments in the management of prostate cancer. So we have two talks, one by Dr. Muralidhar and sir, and one other by Dr. Rajesh sir. After that, I will present few real-world cases which we have managed in the our clinic, and following which we have some few question and answers. So without much waste of time, I would like to invite Dr. Murali sir to talk on reaching new heights in the metastatic hormone-sensitive prostate cancer care. Over to you, Murali sir.
Very good evening. Can you see my screen?
Yes, sir. We can see this.
Yes, sir. Yes, sir.
Thank you, Stalin. Thank you for Bayer for giving this opportunity. Today I am going to discuss about the newer drugs and reaching the new heights in metastatic hormone-sensitive prostate cancer care. So we all know the prostate cancer landscape. Majority of patients presented with localized prostate cancer. After localized treatment, some patients may develop biochemical recurrence, some patients may develop metastatic disease. Ultimately, they turned into the castrate-resistant prostate cancer and followed by the death. So previously, 10 years back, we don't have a much drugs in castrate-resistant prostate cancers and sensitive prostate cancers. Now there is a plenty of drugs, so we can sequence them and we can improve the majority of patients' life. So these are a lot of trials showing good number of drugs approval like docetaxel and abiraterone and enzalutamide, apalutamide, and there are now recently is the darolutamide showing the good survival benefits in the sensitive hormone-sensitive prostate cancer. So we now have a good amount of drugs, but which drug we have to choose and which combinations we have to choose, that is based on the lot of factors. So, but there is a lack of comparative data supporting the one drug over another. It is mainly the choice mainly depend upon the toxicities, drug-drug interactions, and the patient profile. These are all will help into guide the treatment. So, choice of therapy mainly based upon the volume and risk of the disease. So previously, 10 years back, we don't have any PSMA scans. Majority we have depends on the only in the conventional imaging CT MRI. So we missed majority of low volume, low risk diseases. But we are using now PSMA scans, so we can now we can divide the patients into low volume and high volume disease. So at the same time, we can also risk stratify the high risk and low risk. Based on the risk and volume, now we can decide the choice of therapy. Suppose if the patient has a high volume or high risk disease, definitely if patient is a fit, we should give the triplet therapy. That is docetaxel, either darolutamide or abiraterone based therapy. For patients have low risk disease or low volume disease, or doublet therapy is sufficient, whether it is ADT plus abiraterone or docetaxel and enzalutamide, like that. So what is the definitions of high risk and high volume disease? Majority of just we are reviewing again. High risk disease means out of three, if patient has a more than two or more than two, they classified as high risk. Presence of visceral metastasis like liver and lung metastasis, or Gleason score more than 8, or more than or 3 bone lesions. High volume disease means presence of visceral metastasis or more than 4 mets, bone mets, one outside the vertebral body and pelvis. So this is the first trial we will discuss, Stampede trial. This is the landmark trial in the prostate cancer treatment. So it had a multiple arms. Standard arm is androgen deprivation therapy. It had other arms like docetaxel, abiraterone plus enzalutamide. They have multiple arms involved in this trial. This trial gave multiple treatment options in metastatic castrate-sensitive patients and non-metastatic castrate-sensitive patients also. This is one of the landmark trial in the prostate cancer. So, if you see the control arm Stampede trial, the median OS and PFS are median OS are around 12 months, median PFS around 12 months, median OS around 42 months. If you using only control arm, that is only androgen deprivation therapy. So, if you add a localized radiation therapy, it is one of the arm in the Stampede trial. If patient has a low volume disease, if you add radiation along with androgen deprivation therapy, the OS, there is a PFS benefit is there, but that PFS benefit is not seen in the if there is a high volume disease. So in hormone sensitive prostate cancer, if you want to give radiation, the disease should be in the low volume disease. So there is a lot of clinical practical changes by the Stampede trial. So if you see abiraterone and the abiraterone first time we added based on this trial, abiraterone and ADT combination therapy significantly improving the PFS and OS in both metastatic and high risk non-metastatic patients also. Abiraterone showed the benefit. So another drug also showed the benefit with combination with ADT, docetaxel. If you use docetaxel, it also showed the benefit, OS and PFS benefits, along with radiation therapy. So if there is a low volume, low risk patient, if you add radiation to prostate, also showing the some PFS benefits. So these are the practical benefits changes by the Stampede trial. So one more trial showing the benefit of docetaxel is Charted trial. It is mainly included the it mainly shows with the docetaxel arm along with ADT compared to ADT. So it shows good benefit improvement OS in high volume disease. Coming to the low volume disease, improvement of OS is not much significant. It's just slightly different to the Stampede trial. Stampede trial, it shows benefit in both high volume and low volume patients. But Charted trial, docetaxel only showed benefit in the high volume, high risk patients. So coming to the another drug in the armamentarium of the prostate cancer is abiraterone. It is one of the wonderful drug and low toxicity drug used in the prostate cancer. The first trial, latitude trial, which shows the benefit of abiraterone if you are adding the ADT in hormone sensitive prostate cancer. If you saw the two arms randomization is the phase 3 trial, abiraterone plus prednisolone plus ADT plus placebo. There is a primary endpoint is OF, overall benefit, and radiographic progression to survival. Second point is the pain progression, PSA progression, skeletal events. So it shows the both high volume, it shows the good OS benefit and PFS benefit in both high volume patients and low volume patients. So, but the consideration for abiraterone in hormone sensitive prostate cancer is we are using prednisolone along with the abiraterone. So majority of diabetic patients or cardiac patients or hypertensive patients, they had some worsening of diabetes, some cardiac status, even though we are using 5 milligrams of prednisolone. This is the only bad part with the abiraterone prednisolone arm. So some patients also had a grade 3 events like hypertension, hepatotoxicity, hypokalemia. These are all we are seeing commonly in abiraterone patients. So coming to the next drug in the hormone sensitive prostate cancer is enzalutamide. So Angelmate trial. This Angelmate trial, one arm is the enzalutamide plus ADT. Another arm is the only ADT plus placebo. So it also shows both PSA progression-free survival and good overall survival benefit compared to the comparative arm. So the good hazard ratio p-value also very significant. If you see the subgroup analysis and overall survival, it shows benefit in the both low volume patients and high volume patients. So the next drug came into the picture is apalutamide. So this is the Titan study, the phase 3 study, the 1:1 randomization, apalutamide 240 milligrams per day along with ADT. Another comparator arm is ADT only. So primary endpoint is again OS and radiological progression-free survival. So it also shows very good progression-free survival and overall survival benefit with good significant p-value. It shows both good survival in both low volume patients, again high volume patients. So another new molecule and very good molecule now in the picture came to the prostate cancer is darolutamide. So darolutamide in the prostate cancer is a 3 trials at present approval by the FDA. One is the Aramis trial. It is mainly studied in the non-metastatic castrate-resistant prostate cancer. Second one is the ARANET trial. This is in the ARANET trial and ARASENS trial both in the hormone-sensitive prostate cancer with different subgroup profiles. So coming to the ARANET trial, it is also phase 3 trial. It is a 2 arms, 2:1 randomization. Darolutamide 600 mg BD plus androgen deprivation therapy. Second arm is the ADT plus placebo. The primary endpoint is the radiographic progression-free survival. Second endpoints are the OS or time to PSA progression. So if you see these curves, after 24 months, if you see the stratification, radiographical progression-free survival are around 70% is shown in the darolutamide plus ADT group compared to the placebo plus ADT, around 52%. It shows very good significant hazard ratio and significant p-values. So if you see the subgroup analysis in ARANET trial, it shows benefit in the all subgroups. Even it is show good results in the even high volume and low volume disease. It shows benefit in the all subgroups. So based on this, these are the number of drugs we approved in the hormone-sensitive prostate cancer like docetaxel, enzalutamide, abiraterone, apalutamide, darolutamide. So these are all the mainly these drugs all useful along with ADT in the low volume, low risk patients. So if you come to if you combine with these drugs with another drug like if you combine with hormone signaling agents along with docetaxel, along with ADT, we can improve further outcomes. So we have the 2 trials. One is the PEACE trial. This is the abiraterone based study. This is the 2:2 factorial design. With the 4 arms. One is the standard of care. Standard of care means it is a ADT or ADT plus docetaxel. Second arm is the standard of care plus abiraterone. Third one is the along with radiotherapy. Fourth one is the standard of care plus abiraterone plus radiotherapy. So if you see this one, phase 1 study, these curves. So ADT plus docetaxel plus abiraterone, it show good OS benefit and PFS benefit in high volume disease. So for low volume disease, there is not a significant benefit with the triplet. So if you use, if there any patient treated with a high volume, high risk patients, we should use definitely triplet therapy based on this data. So these radiographic progression-free survivals also if you see the curves are very separating. So very good p-value and hazard ratio. So you see the individual arms. If you give only ADT in this high volume disease, the median survival around 35 months. If you see the ADT plus docetaxel, around 40 to 48 months. You see the ADT plus abiraterone, around 50 to 56 months. If you combine triplet, ADT plus docetaxel and plus abiraterone, the survivals are improved. So based on this study, if any patient presented with a high volume, high risk patients, If the patient is fit to take docetaxel, definitely we should combine treatment with the triplet therapy. So another drug also showed the benefit in high risk, high volume patients is darolutamide. This is the ARSENS study. This is also globalized randomized double blind placebo study. The two arms, one is the darolutamide 600 mg BD plus ADT. Another one is the ADT. So combined with docetaxel, 6 cycles of docetaxel. So primary endpoint is the overall survival. So if you see the curves, darolutamide and ADT, docetaxel showed the favors compared to the placebo arm. So survival, if you see that after 46 months, also around 62 people are still the patients are surviving compared to the placebo arm. So secondary key endpoints also, see the time to castrate resistance also, it is better compared to the placebo arm. Time to pain progression also better in darolutamide arm compared to the placebo. So if any patients, so these are the two trials, PEACE-1 trial and the ARSENS trial showed the good benefit with the triplet therapies in high risk, high volume disease. So any patient treated with high volume, high risk patients, if patient is docetaxel fit, so definitely we have to give triplet therapy, either with docetaxel with darolutamide, ADT, or docetaxel with abiraterone plus ADT. If the patient is unfit, definitely we have to go for a doublet. So there is a one more drug came into the hormone sensitive. There is a PARP inhibitors. Previously, it was used in the castrate resistance, but recently the recent trials also showed the benefit in the castrate sensitive prostate cancer. This is the amplitude trial. This main inclusion criteria at least more than one HRR gene eligible, BRCA, checker, PAL mutations. There the randomization. One arm is the niraparib along with abiraterone. Another arm is the abiraterone with placebo. So if you see, really 1/3 of castrate sensitive prostate cancer patients have harbor certain some sort of HRR pathway gene mutation, either BRCA1, 2, or other mutation. If the patient had these mutations, these are experienced significantly worse PFS and OS with AR pathway inhibitors. So definitely we have to add these PARP inhibitors along with the AR pathway inhibitors, then we can give the good results. So see the curves also, progression-free survival. If adding the BRCA mutation patients, niraparib and abiraterone showed favors than the abiraterone alone. Subgroup analysis also show it shows the benefit in majority of the HRR pathway abnormalities, but mostly benefits mostly in the BRCA. Remaining, if you see, there is not much benefit. BRCA mutations have showing very, very good results. BRCA2 is getting more benefit than the BRCA1 also. So we have the lot of drugs. So we just there is one such drug is better than another. Just we choose based on the multiple factors, special populations, whether the comorbidities are there, whether hypertension or cardiac or renal or CNS problem patients. So what is the efficacy? What is the toxicities? What is the drug-drug interaction? We have to encounter all these sorry. So we have to choose all these factors before going to the treatment. Thank you.
Shalin sir?
Yeah, Sandeep, I'm there. So thank you, Murli sir, for delivering a nice lecture on the recent insights in the management of metastatic hormone-sensitive prostate cancer. So we'll move on to the next talk, and we'll discuss all these points in the question and answer session. So what are the best ways in which we manage the metastatic hormone-sensitive prostate cancer? We move on to the next talk by Rajesh sir on advancing hormone-sensitive prostate cancer treatment horizons, darolutamide without chemotherapy, the R-Note evidence. Over to you, Rajesh sir.
Thank you, Stalin. I think you can see my slides.
Yes, sir. Slides are visible and you are audible, sir. Please.
One second. Yes. Yeah. Thank you, Sandeep. Thank you, Bear, for getting us together for today's discussion on darolutamide in the use of metastatic hormone-sensitive prostate cancer. So I'll be focusing more on the ARANOTE evidence, that is the usage of darolutamide without chemotherapy. Sandeep, my slides are not, yeah, thank you. So the standard of care, as Dr. Murli was discussing in metastatic hormone-sensitive prostate cancer, has evolved to combine the androgen deprivation therapy with AR inhibitors, abiraterone or docetaxel. And for the last 10, 12 years, we have seen a lot of additions to the armamentarium of the treatment of metastatic castrate-sensitive prostate cancer, beginning with the chartered and stampede, the different arms of stampede, latitude, compared abiraterone. Archie's introduced us to the enzalutamide. The Titan data showed the benefit with apalutamide. The Enzamet tested triplet versus doublet. Arasens, the phase 3 trial that showed the benefit of using darolutamide along with docetaxel with ADT. That led to the approval in this particular indication. And now in the latest data, what we are discussing today would be a doublet, darolutamide along with ADT, that is the ARANOTE trial data. So despite the treatment with androgen receptor pathway inhibitors plus ADT, androgen deprivation therapy, or docetaxel plus ADT, a significant number of patients with metastatic hormone-sensitive prostate cancer will progress to metastatic castrate-resistant prostate cancers within 3 years. So there is this specific unmet need remains for an efficacious treatment that offers a differentiated and improved safety profile for patients with metastatic hormone-sensitive prostate cancer without adding significant toxicities and with a very low drug interaction potential. So Arasens, as we all know, the phase 3 study in combination with docetaxel has already shown the beneficial efficacy and safety profile of profile of darolutamide in the metastatic hormone-sensitive prostate cancer setting, leading to its approval in India in 2023. So now, darolutamide in combination with ADT would provide efficacy benefit with a favorable safety profile in metastatic HSPC patients, as demonstrated in the ARANOTE phase 3 study, with significant number of Indian patients included in the study. With the ARANOTE data, darolutamide has the potential to change the treatment paradigm, as now it would be the only androgen receptor pathway inhibitor which could be used with or without chemotherapy. So that gives us a lot more potential options for elderly patients who might not tolerate the triplet regimen. So coming to the background of the study, darolutamide plus ADT with docetaxel is the standard of care in fit patients. The Arasens data, where darolutamide plus ADT plus docetaxel, it has demonstrated favorable efficacy and safety versus ADT plus docetaxel in the metastatic HSPC patients. ARANOTE, it is designed to evaluate darolutamide along with ADT versus ADT alone. So that is the catch. So we are comparing with only ADT, which might not be the standard of care right now in many of our patients, but it would potentially throw us a new option to treat these borderline fit or unfit elderly patients. So it has tested, it is a 2:1 randomization. The patients being metastatic hormone-sensitive prostate cancer patients, histologically, cytologically confirmed adenocarcinoma of the prostate with a reasonably good PS. PS2 is also allowed. The stratifications being visceral mets as assessed by the central review, whether any prior local therapy has been given or not. So the randomization is 2:1 darolutamide 600 mg BD, that is almost 4 tablets of darolutamide along with ADT versus placebo plus ADT. So the primary endpoint in this particular trial is radiological progression-free survival. The key secondary endpoints being overall survival, time to initiation of subsequent therapies, time to progression to castrate resistance, time to PSA progression, rates of undetectable PSA levels, time to pain progression, safety, and other pre-specified endpoints being the PFS2 that these days we're using to evaluate the OS, it as an OS proxy, time to skeletal related events, and time to deterioration of fact P total. So as on data cutoff on June 7th, 2024, the median follow-up for the study drug and the placebo is around 25 months. And it is an open label study and 100% crossover is allowed. Reasonably well distributed across races. So the Asian population included in the study is almost 32% in the study drug and 30% in the placebo arm. And the ECOG performance status, so 0 is in around 50%, 52% of the patients, whereas ECOG performance 1 or 2 is there in almost 50% of the patients. Gleason's more than 8, the high risk group has been included in the study. About 70% of them comprised of having Gleason's 8. The serum PSA median range is around 21 in both the arms. The metastatic disease at diagnosis, de novo metastasis, 71, 70 to 75% in both the arms. 1/4 of them had recurrent disease. Coming to the disease volume, high volume comprised 70% of the patients, and the presence of visceral mets is there in around 11 to 12% of the patients in both the arms. So, well studied design. So across if you see the Aeronaut trial here, so the study is distributed across the globe. So representation from Asia Pacific region, South American and North American region also. So even Chinese population have been included. The Indian population had representation of about 13%. So reasonably good inclusion of the Indian subpopulation also. Darolutamide plus ADT, if you look at the Kaplan-Meier curve for the radiological progression-free survival probabilities at 24 months. The radiological progression-free survival was 70% for the darolutamide plus ADT arm when compared with only 52% in the placebo plus ADT arm. The hazard ratio being 0.54. So 46%, almost 46 to 50% risk reduction in having radiological progression or death when we use darolutamide in the first line treatment. So again, the subgroup analysis of radiological progression-free survival. So all the subgroups favored the darolutamide arm, whether irrespective of the age, irrespective of the PSA levels, ECOG performance status, Gleason score, high volume or low volume. In fact, is better, more significant in the low volume disease setting. Coming to the Asian subpopulation, so just reaching the line of, it is just touching the center line. So geographical region, visceral mets, everything was favoring the darolutamide arm. So coming to the OS, so it is not statistically significant. Time to metastatic castrate resistant progression is statistically significant when we use darolutamide. Time to PSA progression, time to initiation of subsequent therapies, all are favoring the darolutamide arm. The OS might be influenced by the 100% crossover allowance. So lot of patients might have been crossed over to the study drug at progression. At the time of primary analysis, the OS data is still immature. Since OS is immature, patients will be followed until survival, and all remaining per protocol placebo patients offered crossover to darolutamide after the primary analysis. If you look at the secondary endpoints of time to pain progression, again, the event-free probability of progression to metastatic castrate-resistant setting is significantly different. The hazard ratio being 0.40, 60% risk reduction of progression to metastatic castrate-resistant setting. The median is not yet reached in the study drug, whereas the median is about 13.8 months in the ADT only arm. And again, the benefit of delaying time to pain progression is also significantly better when we use darolutamide, the hazard ratio being 0.72, and the median is not yet reached. So, and the use of darolutamide actually achieved a deeper and durable PSA responses also. So, 60%, 63% of the patients actually had a significant improvement in terms of deeper PSA reduction, that is PSA levels of less than 0.02 nanograms per ml. So this represented 69% improvement in time to PSA progression in the darolutamide arm versus ADT alone. So in all the pre-specified secondary endpoints, darolutamide fared significantly better with very significant hazard ratios and risk reduction. Say a higher proportion of patients achieved undetectable PSA with darolutamide versus placebo. So you can see the numbers in at different time points, 24 weeks to 48 weeks. So you can see significantly higher number when compared to using ADT alone have achieved a deeper response, irrespective of whether the patient is having high volume disease at diagnosis or low volume disease at diagnosis. So subsequent life prolonging anti-cancer therapy. So the patient who discontinued study treatment is around only 45% in the darolutamide arm, whereas it is 71% in the placebo arm. And the subsequent therapies being docetaxel, levetiracetam, other ARPIs, cabazitaxel in a select few, radium and olaparib in very few patients. So this is the incidence of treatment emergent adverse events. It is similar between the two arms. Any adverse events is around 90% in both the arms. Grade 3 or grade 4 also very similar, 30% across both arms. Serious adverse events are only 1/4 of the patients achieved serious adverse events. So treatment emergent adverse events leading to permanent discontinuation is seen only in 6% of the patients in the darolutamide arm, whereas it is 9% in the placebo arm. The median treatment duration was 24 months, around 2 years in the darolutamide arm, as compared to around 17.3 months, that is 1.5 years in the placebo arm. The safety profile of darolutamide in ARANOTE was independent of PSA response, so consistent with its mild or tolerable safety profile of darolutamide. Coming to the rates of most common adverse events, they were across the table very low in the darolutamide arm, and it is very similar to offering placebo plus ADT. The minor adverse events being anemia, arthralgias, UTIs, back pain, liver function dysfunction, hot flushes, constipation, hypertension, bone pain, increased weight. All these are similar across both the arms. So this is the list of all the adverse events. So it also confers a positive impact on the health-related quality of life issues. This paper presented at ASCO 2025. Darolutamide extended median time to deterioration in the FACT-P total score by 5.1 months when compared to placebo. And darolutamide is the only androgen receptor inhibitor to demonstrate a clinically meaningful delay in pain progression and overall well-being. with a significant hazard ratio. So there is about 5 months improvement in the median time to deterioration. So daralutamide doublet therapy, it demonstrates clinically meaningful delays in the deterioration of overall well-being, especially on the social, functional, and urinary symptom domain in these particular domains. So to conclude, the doublet, that is darolutamide plus androgen deprivation therapy, significantly improved the radiological progression-free survival in patients with metastatic hormone-sensitive prostate carcinoma. Darolutamide showed a benefit across all secondary endpoints like overall survival, time to second treatment initiation, depth of PSA, progression to castrate-resistant disease, deterioration of overall health and health-related quality of life issues. So across all secondary endpoints, darolutamide showed a significantly meaningful improvement when compared with only ADT. Darolutamide was associated with a deep PSA response regardless of the baseline PSA, and it is the first and only androgen receptor inhibitor to demonstrate clinically meaningful delays in pain progression, overall well-being, social and family well-being, functional well-being, and urinary symptoms. And it has a favorable safety profile. So darolutamide and ADT without docetaxel can also be an additional standard of care for borderline or very elderly hormone-sensitive prostate cancer patients. So I think with that, I conclude my talk. Thank you. I'll hand over back to Stalin.
Thank you, sir. So next session, so we have two talks on the recent advances in metastatic prostate cancer. So I'll be discussing few cases, and after that we had a small question and answer session. Hope my slides are visible.
Sir, slides are visible. Is it possible for you to, switch on your camera, sir?
Yes, yes, yes.
Yeah.
Okay.
Perfect, sir.
So a few cases what we managed in metastatic hormone sensitive prostate cancer I will discuss. So I'll be telling about the three cases. After that we'll have a small question and answer session. This is the first case where we will be demonstrating the real world efficacy of triplet therapy in a complex metastatic castration sensitive prostate cancer, validating the Arison's trial outcomes in an elderly cardiac comorbid presentation of high volume metastatic CSPC. And we all know that so the main advantage of using this Arison's data is the use of darolutamide combinations along with the docetaxel. So we all know that majority of the times when the patient is too elderly, so there is a lot of polypharmacy and lot of medications, and darolutamide is a drug with less drug to drug interactions and very safe and comfortable to give in the real world setting. So this is a 77-year-old male, so who presented with lower urinary tract symptoms with comorbidities like coronary artery disease with a CABG, hypertension, diabetes mellitus, but he is in good performance status. So his baseline PSA was 349. So a PSMA PET was done. High volume metastatic disease. The histopathology showed a prostatic adenocarcinoma with a Gleason score of 9, which was confirmed by IHC. And in the PSMA PET, high volume metastatic disease was there. Primary lesion is in the prostate with widespread nodal metastasis and multiple sclerotic bone metastasis. And we classified the patient as a high volume metastatic CSPC. And we started, so majority of the times the ADT I follow is relugolix, which is an oral GnRH receptor antagonist. And along with the docetaxel, which was planned for 6 cycles, and darolutamide 600 mg. So in my clinic, so majority of the times I do either a 2-weekly docetaxel or a 3-weekly docetaxel. If the patient is frail, not able to tolerate 3-weekly, I can do it 40 to 50 mg per meter square once 2-weekly. The patient is fit and able to tolerate a 75 mg per meter square of docetaxel, I will do it 3-weekly. So the rationale is Arison's trial. We had an extensive discussion and talks on this Arison's trial, which showed a clear survival benefit for high volume metastatic castration-sensitive prostate cancer. And this patient matches it for a fit elderly patient with good performance status. And darolutamide was chosen specifically for its highly favorable cardiovascular and CNS safety profile, crucial for a patient with a history of CABG. So after we start this, within 1 to 1.5 months, there was a rapid decline in the PSA. More than 99% PSA decline was there, demonstrating a rapid and deep biochemical response within first 4 months of darolutamide-based therapy. So this is the baseline PET-CT scan, and the follow-up showed an excellent response to the therapy. So efficacy versus tolerability, we attained a deep response, near complete metabolic response on the PSMA PET-CT scan. Immediate symptomatic improvement of initial lower urinary tract symptoms. No significant grade 3 adverse events are observed, and excellent tolerability despite advanced age and prior CABG, and good treatment adherence was maintained throughout the cycles. So high volume metastatic castration-sensitive prostate cancer fundamentally benefits from triplet therapy. Darolutamide-based regimens produce extremely deep and rapid biochemical suppression, which directly correlates with near complete radiological response, and the treatment maintains an excellent safety and tolerability profile even in medically vulnerable elderly patients with significant cardiac comorbidities. So this case provides a definitive real-world reinforcement of the ARASENS trial outcomes, proving that aggressive life-prolonging triplet therapy doesn't have to be compromised by age or controlled cardiac history. So this is the first case. Moving on to the second case. So this is a case of a patient who is a 66-year-old male, so who had a prostatic adenocarcinoma with a Gleason score of 9, and the PSMA PET-CT scan showed an extensive disease and multiple skeletal cells, almost like a super scan features. So in this patient, so we administered Degarelix 240 mg subcutaneous first month, followed by 80 mg subcutaneous monthly. And in this patient, so because of his frailty, so we used docetaxel as a 50 mg per meter square once 2 weekly for 9 cycles along with darolutamide. So due to logistic issues, the patient procured or started the darolutamide after 2 months after starting the ADT and docetaxel. So we have used a sequential initiation of triplet components. This can be done. So in few patients who are not able to tolerate docetaxel at diagnosis, some patients may have been a wheelchair bound or not able to and do because of the performance status. I usually do it ADT plus some newer anti-androgen. If once the performance starts increasing, I use a triplet combination. Docetaxel I will add later. So for this patient, docetaxel course completed in full 9 cycles and darolutamide added once chemotherapy was underway. So there was, after 3 months, there was a good PSA response, and 5 months, an excellent PSA response of 3.4 nanogram per ml, more than 98% PSA reduction from the baseline. So this is an excellent response to the PET-CT scan, and follow-up PET-CT scan showed a good and partial response to the treatment. So darolutamide-based triplet therapy resulted in a near complete metabolic response on PSMA PET-CT scan, excellent tolerability in an elderly patient, and this also reinforces the real-world data of ARASENS trial. The third case, this is a bit tricky case, so which is a high-risk de novo metastatic hormone-sensitive prostate cancer in a quite young patient, and this shows the biological imperative of continuous androgen axis suppression. So what happened is, this is an 66-year-old male. Sorry, this was a mistake. So he's an 56-year-old male. So who presented with lower urinary tract symptoms with a PSA of 200, and we had a Gleason score of 9. Bone mets were positive, and biochemistry showed a PSA of more than 100. We diagnosed it as a metastatic hormone-sensitive prostate cancer. The patient fits into the both charted and latitude criteria of high risk and high volume disease. We had started the patient on relugolix along with chemotherapy, along with darolutamide based upon the ARASENS trial design. There was a rapid decline in the PSA by month 2, and upon the completion of the docetaxel chemotherapy, the PSA was almost less than 0.1, which had a rapid deep PSA response with the triplet therapy. So there was an excellent response post-treatment, marked reduction in the disease burden following the triplet therapy. But due to some logistic reason, patient stopped the darolutamide for 4 reasons, and within no matter of time, so upon stoppage of the darolutamide, there was a rapid shoot of rise of the PSA. The patient was lost to for 4 months, didn't use anything, and it has shoot up for the 34. And this PET-CT also showed there is a gross progression of the disease, which is observed during the darolutamide interruption. So we have resumed the darolutamide, and post resumption, the PSA starts declining. So this shows the need of continuous suppression of the androgen axis in a case of metastatic hormone sensitive prostate cancer. So high volume, high risk de novo metastatic hormone sensitive prostate cancer is acquisitively sensitive to aggressive initial intervention. Triplet therapy achieves rapid, profound biochemical response and radiological remission, but treatment interruption triggers rapid, dangerous biochemical and radiological progression, proving initial deep response is not a cure for these patients. So rechallenge reaffirms persistent androgen dependence and continuous uninterrupted androgen axis suppression is absolutely critical for the sustained survival. So, this we all know this has been discussed by Murli sir, the advanced prostate cancer, castration sensitive. It can be a relapsed case or a de novo case. So, we have multiple treatment options for these patients, and we classify the patients into either metastatic hormone sensitive prostate cancer into either high volume or low volume disease based upon the charted definition, or high risk or low risk based upon the latitude disease. So, this is the why we need to stratify is those patients who have a low volume low risk disease tends to do extremely good compared to the patients who have a high volume and high risk disease. The median survival varies according to this. So why what is the evolution of these treatments in the management of metastatic hormone sensitive prostate cancer? Way back we have used only ADT for these patients, either orchidectomy or some form of GnRH agonist or antagonist, which produced a median overall survival of approximately 42 months. Thereafter, chemotherapy came into the picture. So we added chemotherapy and produced an extra 14 to 16 months benefit over the ADT alone. So all the trials like Charted, Getic 15, Stampede, which had shown that addition of docetaxel improves the survival by extra 14 to 16 months, which has overall hazard ratio of 0.77. Thereafter, the newer anti-androgens and newer androgen inhibitors came into the picture like abiraterone, which almost showed a similar survival to compared to the docetaxel with a hazard ratio of 0.62, addition of 17 months of ADT alone. Thereafter, various new drugs came into the picture, Enzamet, Titan, Latitude, and Stampede, which also showed similar overall survival benefit upon addition. Thereafter, there came a discussion whether for a low volume, low disease, whether radiation therapy can be used. Yes, for a low burden disease, definitely you can add radiation to the treatment paradigm. Once there is a good response after 6 months, you can produce a significant overall survival benefit. But for a high risk, high volume disease, there might not be any role of this disease. So now we slowly moved on to the era of various triplets. The two triplets which we routinely use in the management of metastatic hormone sensitive prostate cancer are the either the abiraterone combinations or the darolutamide combinations. Abiraterone combinations are based upon the PIS1, and Arasen's combination is for the darolutamide combination, which is approved for the fit and high volume patients. Various doublets are available. Enzamet, Archie's Titan has showed the role of enzalutamide, apalutamide along with ADT. But recently, in 2024 and 2026, the doublet combination with darolutamide has been reinforced, and Arnaut has been now approved, and we can use ADT without chemotherapy with only darolutamide also. So to manage simply the algorithm of metastatic hormone sensitive prostate cancer has been changed into, if it is a high volume disease, whether it is a metachronous disease or a synchronous disease, always try to prefer and consider the triplets. Either it could be abiraterone based or a darolutamide based triplets. If at all it is a low volume synchronous or metachronous disease, almost always majority of the times in our clinic we tend to do doublets, but there is a data to use triplets, especially in the younger population too. So with this small background and with few cases which has been discussed, so I want to ask both the speakers today, Dr. Rajesh sir and Murali sir, a few questions on how they manage the metastatic hormone sensitive prostate cancer in their clinic. So Murali sir, which patient phenotypes most clearly tip you towards ARI doublet versus triplet intensification? Hello, Murali sir?
I think he's not there, so I'll take the question.
Rajesh
So,
sir, yes.
yeah. So, definitely all of these factors will take into consideration. But if you ask me one to choose, it would be frailty. So, frail elderly, maybe to begin with, I'll start with a doublet, and once the symptom burden reduces, and if he's doing well, as you said, I can sequentially add the third component, that is the docetaxel. So coming to disease volume, definitely yes, majority of our patients come with high disease volume. Almost 80 to 90% of all de novo metastatic prostate cancers in my practice have high volume disease. So if age, performance status, and the fitness of the patient allows me, I would start with a triplet regimen. Visceral involvement, again, as I said, very rare for a de novo patient to have visceral metastasis at diagnosis. That is not a practically, yes, if there is visceral metastasis, I would prefer triplet, but in my practice, majority would have bone only disease or the max lymph node mets and one or two um, uh, liver disease, liver metastatic disease. Symptom burden, yes, if the patient is very symptomatic, I would definitely choose a triplet rather than a doublet.
Yes, sir. I too agree with you. The next question is, when abiraterone or enzalutamide combinations feel suboptimal, what are the most common clinical or practical triggers? The steroid requirements, cardiometabolic risk, CNS-related concerns, or drug-drug interactions, or the adherence? So what are the practical or clinical triggers to use a darolutamide combinations for you?
Yeah, majority of our elderly patients are on for polypharmacy, so definitely we would like to avoid steroids. Major 50% of them would have diabetes at diagnosis, so I would prefer a steroid sparing regimen wherever possible. Cardiometabolic risk, yes, definitely there for all of our patients, and CNS, especially very old patients now we are seeing in their late 80s also, so they're willing to get their treatment. So very elderly patients, again, CNS related concerns with enzalutamide are a problem. And drug interactions, as I said, polypharmacy, definitely we would prefer the drugs having least drug interactions. Yeah.
Okay. So which are
Adherence is actually against this darolutamide. The patient has
yes,
to
yes,
take
yes, sir.
four tablets when compared to enzalutamide. Now we are
Yeah,
getting
yeah.
160 mg enzalutamide also. Yeah.
Yes, yes, yes. So which Aronaut stents most impact adoption versus currently approved doublets? Do you consider Aronaut's radiographic progression-free survival HR comparable to other ARA trials? And how does that affect first-line confidence in you using this Aronaut combination?
Hmm. So definitely the rapidity of the PSA fall, and that is astonishingly fast. So I recently had a patient, so he was put on darolutamide just a couple of weeks back. So it was more than 200 or 300. So within 2 weeks, it has come down to 35. The patient's party or patient's attendants were actually questioning the lab's authenticity. So the rapidity of PSA fall is real, and it is it is definitely uh, uh, it gives a good feeling for the patient also that his disease is reducing. And radiological progression-free survival, very good hazards ratio. So the data is very clear that darolutamide in combination with ADT, with or without docetaxel, had very good delay in the radiological progression-free survivals.
Sandeep, did Murlisa join?
No, sir. I think I
Okay.
don't see
How
sir.
do the volume data clarify the appropriate patient for treatment intensification with darolutamide plus ADT with docetaxel? Does the Addison's data support the use of darolutamide ADT with docetaxel in low volume HSPC? So, what is your practice in low volume HSPC, and how will you choose the treatment for a high volume and low volume disease in your practice?
Yeah, high volume disease patients, definitely triplets docetaxel I'll use, if not at diagnosis, maybe 1 or 2 months later. And with the Aranode trial, so I think it is time we can shift at least few of our low volume patients. So in practice, we'll get very few number of low volume metastatic HSPC patients. So wherever possible, I think with the data on error note, I think we can start using the doublets in select few low volume disease patients.
So in your practice, what characteristics, as we have discussed also, so what characteristics define patients who are ideal candidates for darolutamide-based doublet therapy versus alternative regimens?
So basically, darolutamide, where it scores is the very safe drug, less drug-drug interaction. So in all practical sense, darolutamide is a ideal drug to have because of the tolerability and similar or even better efficacy in reducing the PSA and symptom delays also. So darolutamide doublets, yes, in elderly patients, comorbidities, maybe who we seem or we deem unfit for docetaxel therapy. I think we can go ahead with the darolutamide doublet therapy as compared to the other ARPs like abiraterone or enzalutamide. So maybe darolutamide in the first line may be scoring. We don't have head-to-head comparison, but practically speaking, I think it will score better than those drugs.
Yeah, this has been already discussed just now.
Yeah.
How do potential drug-drug interactions influence?
Yes.
Definitely, it influences our
Right.
decision making. How Indian oncologists approach treatments sequencing to preserve options at metastatic castration resistant prostate cancer stage in the
So
use of these data.
the paradigm is shifting towards using all possible drugs at diagnosis rather than keeping them for a later stage, not just in the prostate cancer setting, in all settings, especially in the breast cancer. What we are seeing is use as many HER2 agents at the earliest possible. So we want a depth of response, very quick response as soon as possible, and so that the quality of life and maybe we don't know the exact data, but the survivals might also improve. So the data we have, especially the Arasense and Enzamide, combining docetaxel along with the chemotherapy along with ARPIs with ADT, the triplet strategy has definitely improved the progression-free survivals.
Yeah, thank you. Thank you for sir for your insight. So this is the 2026 treatment message. So ADT backbone is essential. Androgen deprivation remains foundational therapy for all metastatic hormone-sensitive prostate cancer treatment strategies, providing essential testosterone suppression. So ADT alone is obsolete. So we had seen excellent survival improvement with the usage of doublet combinations and triplets. So using ADT alone is obsolete now. And with the doublet combinations with newer and newer androgens, the treatment delivery is also simple. So you may not be always able to deliver a docetaxel-based doublet, but ARPI doublets are the standard. And the combinations can be one of the newer androgen receptor pathway inhibitors. They represent current standard of care for majority of the hormone-sensitive prostate cancer patients. And for aggressive disease, high volume, high risk disease, so definitely triplets combination offers greater survival benefit, particularly for fit patients with de novo high volume disease. But patient fitness assessment is crucial for triplet consideration, including the performance status evaluation. Thank you. Thank you, Rajesh sir and Murli sir for wonderful talks, and Rajesh sir for the nice discussion for the questions. So thank you all, and I hand over to Bayer.
Thank you, sir. Thank you all. Before we close, let me check the chat box, sir, if any questions are there. Yeah, I don't see any questions in the chat box, sir. With this, we can conclude the session. My sincere thanks to Dr. Rajesh sir for presenting the data on Aranode, and also Dr. Muralidhar sir for presenting the data in triplet RSNs. And thanks to Dr. Stalin sir for all your support in terms of presenting your case presentations by taking your time. So with this, I thank to all the audience. We had around 42 plus audience from across India. So with this, we can conclude the session, sir. Thank you so much, sir. Good night all.
Yeah, thank you. Thank you.
Thank you.
Thank you,
Good
sir.
night.
Technical team, we can close the session. Please. Technical team.
Yes.
Yeah, please end up the session. Thank you.